Hi, everyone. I'm Dr. Michael York, a rheumatologist from Boston University Medical Center, and I'm here with my colleague, Dr. Christina Lamb of our dermatology department, to talk to you today about localized scleroderma or Morphea. We see patients together in the dermatology rheumatology clinic, and we're going to talk to you about our approach to this unique disease. So the first thing I want you to come away with is knowing how does localized scleroderma, which we're going to refer to as Morphea today, how does that differ from what most people call scleroderma, which is also called systemic sclerosis? The naming is very difficult. Both types of disease are scleroderma under the microscope, but in practice, the way they behave, they're completely different diseases. And we're going to go through the different reasons for that. Dr. Lamb is going to take you through the different patterns of localized scleroderma, and we're going to go through how we assess disease activity, how we can tell if treatment is working, when we can stop therapy, and go through some of the different treatment options. So the main thing today is to understand how does Morphea differ from what most people call scleroderma, which is the one that affects the internal organs. Systemic sclerosis affects the vascular system, the pulmonary system. It's associated with a lot of immune dysregulations. So in Morphea, we don't see any of these things. We don't see Raynaud's, where your fingers turn color in response to cold. We don't see heartburn or gastroesophageal reflux any more than we would in a patient in the general public. The anti-nuclear antibodies, which are seen in lupus and scleroderma, are not seen in Morphea. There's no change in life expectancy, and although the disease can be very deforming in its skin manifestations, it doesn't have the internal organ complications. So for this talk, we're going to refer to Morphea as localized scleroderma as Morphea, and systemic sclerosis is scleroderma. Morphea is actually much more common than systemic sclerosis and can occur both in children and in adults, although they tend to have different patterns of Morphea.
So we classify Morphea really based on what we see. That tends to be the most practical way of approaching it because that would influence how we approach our therapy. And we call that based on clinical phenotype. And so there are 4 really distinct Morphea subtypes that we see. The first one is circumscribed Morphea, or also what we call plaque type Morphea, meaning that you see a single lesion that is often palpable or that you can feel when you pass your hands over them. And these lesions, these plaques, can be superficial, meaning that they are more superficially located in the skin. And so when you pass your hand over it, you can feel oftentimes a little bit of firmness in that area, but not necessarily a lot. And they don't necessarily, and these are not lesions that go deep. Whereas deep, as the name signifies, are lesions that usually the inflammation extends deeper into the skin. And so when you feel these lesions, the tightness and the induration of the skin extends deeper. And this can go all the way through the different layers of the skin, sometimes down into the fatty tissue, sometimes even deeper than that and into the muscle. Then another subtype that we see is linear Morphea, and that can occur in 2 distinct distributions. And as the name says it occurs typically in a linear fashion, as opposed to a single plaque that's often oval shaped. So the linear subtype can occur over the trunk or over a limb. And when it occurs over a limb, we worry when the induration of the skin is occurring over a joint in particular, because that can cause contractures and then functional disability over time, particularly when these lesions are deeper. And then linear Morphea can also occur over the head and the face area. And that can be very cosmetically disfiguring for patients because it is an area that is very visible. There's also a subtype we call generalized, which, as the name states, means generalized. And so it's occurring over more than one anatomic site. And the definition really is at least two anatomic sites. And there are two different subtypes for that. There is a plaque type that can be generalized. So these are plaques like we see in circumscribed or plaque type morphea, but there are many of them and occurring over many parts of the body. And then there's another pansclerotic type, which we'll talk a little bit about in the slides to come. And then the final subtype that we see as well is what we call a mixed subtype of morphea, in which there are more than one subtype that coexist in the same patient. So for example, you can see a patient with plaque type morphea on the trunk and then a linear type of morphea occurring over the arm, for example, and that would be a mixed type. And so here you have a classic photo of morphea plaque type lesion. And you can see when you look here that though it is a little bit subtle, when you pay close attention, you can see that there is a plaque in this area over here and relatively well defined. You can see that the periphery is actually red, or what we call erythematous. And then within the area, you can kind of see this whitish, a little bit shiny area, which when you palpate it, this will be a little bit indurated, a little bit firm. So circumscribed morphea, as I mentioned, we also call plaque type morphea, is the most common subtype that we see in adults. And actually, interestingly, the natural history for each individual plaque tends to be that it slowly softens and kind of gets better by itself over a variable period of 3 to 5 years. However, there are relapses that can occur over time. So when you see a patient with morphea, with these plaque type morphea, they sometimes give a history of lesions that come and go over several years. Lesions present usually in a specific pattern. And so the lesions start off with inflammation. And in the skin, we see inflammation often as being characterized by erythema or redness. And then slowly, as you saw in the photo before, the skin will become fibrotic or tight. And that is characterized a little bit more by that white, shiny look that we saw. And that typically tends to be in the center of the skin. And then in the center of the plaque, sorry. And then as the disease progresses, the lesions will then end up becoming atrophic. So the sclerosis, or the tight part of the skin, will end up becoming atrophied. And so those lesions will be depressed, and you'll be able to palpate them as depression in the skin. And there can also be some pigmentary change, meaning lighter or darker skin associated with that area as the lesions become less inflamed and become more burnt out. There can also sometimes be preceding pain or itch at the site of involvement. And sometimes patients know that a lesion is coming, for example, when they've had more than one lesion, because they feel it symptomatically before the lesions actually start to appear. And so this is just a diagram showing you kind of how the lesions, as we mentioned before, kind of progress over time. So we start off with, on the left, you can see more inflammation. And as the disease progresses over time and evolves, you'll have less inflammation. And then on the right, you can see that we start off with less sclerosis or fibrosis, tightening of the skin. And then as the disease progresses, we get more. And then in the atrophic phase, we end up with less tightening of the skin per se, but then there's more sequelae of that tight skin, which results in depression of the skin with areas that are kind of sunken in. And when the disease ends up being deeper, we can also get muscle that ends up atrophying or shrinking a little bit underneath the area that was affected. And so we start off with inflammation in the skin. And so that's characterized by redness. And you can see here an early lesion of plaque type morphea, where all you see, you don't see that kind of white, shiny, indurated skin. You just see an area of the skin that looks red. And here is another area, a little bit more well-defined than the previous photo. But again, you can see a pretty well-defined plaque, right, that we mentioned before, of redness occurring on the trunk area. And then, as I mentioned before, when the disease progresses a little bit, you start to see early sclerosis, or the skin gets a little bit tight, especially in the center, and the periphery remains red with erythema. And that is a sign that the disease is still active. Like I said, redness often indicates for us inflammation, meaning the disease is active at that point. And that's where we actually want to intervene with our treatments, because inflammation can be treated with our medications. And so here you can see a photo showing you a little bit more of an evolved process compared to the photos before. So you can still see that there is peripheral erythema in these lesions, but in the center you can start to see, and you would be able to palpate if you passed your hand over it as well, that these areas are a little bit firmer to touch. They're a little bit indurated when you touch them. They're thicker as well. And then the redness surrounding it signifies that these lesions are still active. Here again, another photo showing you, we like our photos in dermatology because it can really portray a point, but you can see again the peripheral redness of the inflammation. And then in the center, the skin is starting to get tight and characterized by that kind of white indurated feel when you pass your hand over it. And then as the disease progresses more, you tend to get less inflammation. So the lesions, instead of being more red, will start to turn more brown, and sometimes can turn even lighter than the surrounding skin. We call that hypopigmentation. And then the whiteness tends to predominate more, the tightness in the center of the skin. And so you can see here where the lesions are less bright red that we saw before, it's starting to turn a little bit brown, and that's often a sign of waning inflammation. And in the center, we still have that white sclerotic look. And this is again another lesion which is a little more progressed than that. And so you can see the whitish center that's a little bit hard and indurated, and the periphery is more brown, or what we call hyperpigmented. And again, here you have a lesion where the sclerosis, or the center hardening part of the skin, is actually fading a little bit. And you can see mostly just brown or hyperpigmentation. That's sequelae of the redness that was there previously and the inflammation that used to be there. And then after the inflammatory phase has kind of passed, what we're left with, and this disease can certainly do this, especially when lesions are deeper, you can be left with quite a bit of scarring, as you can see on the photo there. And like I mentioned, when the disease is deeper and affects, more than just the skin, it affects also the bone and the underlying structures, you can get quite a bit of atrophy. And so you can see how there's, the muscle of the leg is actually smaller than the muscle on the other side. We call that atrophy, and that's resulting damage. And so it's much harder to intervene at this stage because it's no longer inflammatory. It's mostly just scarred and damaged. And so here you can kind of see lesions which we would call more burnt out. And so you don't see really much redness or erythema. What you see is mostly pigmentary change. There's some brown, and then you kind of see the little bit of dimpling and sunken in appearance of the skin that's consistent with atrophy. So older lesions tend to kind of sink in a little bit. And again, here you can see a similar look, a little bit more pronounced than before. And the deeper the inflammation goes, the more atrophy and contour change that you tend to get with the damage associated with the lesions as they fade over time. And here you can definitely see an example of that, where there's quite a bit of depression in the skin from the disease that was active before. And in our patients that have darker skin types, the pigmentary change that we see can actually be quite striking, because darker skin type can scar, and the skin gets damaged not only by turning darker, but also sometimes by turning lighter. And so you can get a mix of lighter skin and darker skin at the same time. So another subtype that we see is generalized morphea, as I mentioned before. And the definition of this is it's at least 4 indurated plaques that we see, at least 3 centimeters in diameter, that involve at least 2 anatomic sites. Generalized morphea tends to be symmetrical over the body when it's distributed, and the lesions, the plaques, can actually start to coalesce and occupy a larger area of the body over time. Typically, the lesions will begin on the trunk and then spread more distally, so we call that acrally, over the extremities. But notably, as Dr. York mentioned before, there is no sclerodactyly associated with this disease, which means tightening of the fingers. And that's something that's really much more characteristic of scleroderma or systemic sclerosis, where we would see involvement of the internal organs and not just the skin. So a completely different disease. And here's a photo to show you generalized morphea. So you can see that there are several plaques. Here's one, here's another one, and there's a large one occurring over the waist and buttock area. So it's occurring over 2 anatomic sites. It's more than 3 centimeters, and there's at least 4 plaques or more. And here's another example, a little bit more subtle. And this example is actually in a more inflammatory phase, because you can see that the lesions are actually redder, and there's a little bit of shininess and early sclerosis or fibrosis, tightening of the skin occurring. And you can see a plaque over here, and there's another one over here, and then there's another one over here occurring over the trunk area. And this is just a study actually that looked at the role for skin trauma or friction in the distribution of these skin lesions, particularly in the generalized type. So there has been some evidence that shows that when you traumatize the skin persistently, or friction sometimes from clothing can actually induce or be associated with lesions in those areas. And so in some patients that have generalized morphea, we tend to see the lesions distributed particularly in the armpits, underneath the breasts, around the waist, and sometimes in the thigh areas around the groin. And that's where, we hypothesize that there's friction occurring there from clothing, and that's where the disease tends to go. And now I mentioned before when we were looking at the table of the subtypes of morphea, the pansclerotic type, which is a form of generalized morphea. However, this one is characterized by deep morphea lesions that are occurring in a generalized circumferential distribution and can involve the majority of the body surface area, including sometimes the fingers and the toes. And this usually starts in the pediatric age group before 14 years of age, and can, because of the deep nature of the lesions and because they're so generalized, tend to cause lifelong disability, severe disability, because as the lesions go away, the patient is left with persistent atrophy. And when the disease is deep, as I mentioned before, you can get muscle that, kind of shrinks at the same time. So the underlying muscle and the underlying joints can become involved, and mobility can start to get affected. And so patients can be quite debilitated by this. And here is a photo showing you pansclerotic morphea, where you can see on the left, the entire trunk is pretty much encased in this tight skin. And so it's very hard to move because the skin is so tight. And you can see here that the arms are involved, and the back of the hands as well. Now, linear morphea is the most common subtype that we see in children. And there tends to be 3 variants that we see depending on the distribution of linear morphea. So there's the one we call en queue de sabre, which is the name kind of says it in French, but it means like a knife-like lesion. So it occurs typically over the head and the face area. You can also get over the face area something we call progressive hemifacial atrophy, also known as Perry-Romberg syndrome. And that is where you can get atrophy again. So kind of depression, sunken in appearance of the skin occurring over half of the face, so hemifacial, and then progressive, meaning that the disease progresses over time. And then, as I mentioned earlier, linear morphea can also occur in addition to the head area over a limb. And so that's linear limb involvement. And so here is a classic photo showing you en queue de sabre morphea. And you can see how very linear it is. There's a little bit of shininess to the skin. When you touch it, it can be a little bit indurated as well. And you can see it's actually quite well defined over this area, extending from the scalp all the way down to about the mid forehead. And classically, it occurs on the side of the forehead, not exactly in the center. We call it paramedian because it's a little bit off center. And very classically as well, you get alopecia associated with these lesions because the fibrosis in the skin can destroy the hair follicles. And so you end up with an area where there's no hair. And we call that alopecia, as you can see over here. And here's a more dramatic and more extensive example of linear morphea or en queue de sabre morphea occurring over the head and the face. And you can see, as I mentioned before, the characteristic alopecia or hair loss associated with it in this linear fashion. It's a little bit off center, not quite in the center of the forehead, a little bit off center, and you can see the depression. So the atrophy of the tissues, the sunken in appearance, it's a little bit brown, as we mentioned kind of before, some changes that can occur. And then you can see also in the middle of it, a little bit of whiteness that, shows us the induration that's in that area. And another angle shows you really the atrophy of the tissue here and how depressed and sunken in the tissue can look, which can be very cosmetically disfiguring for these patients, particularly because they happen a lot in children. And children's facial structures are still growing over time. And so when they finally reach adulthood, you can get quite a bit of cosmetic disfigurement because half of their face will grow and the half that's fibrosed and indurated will not grow. And so you can end up with quite a bit of change in that way. And here you can see an example of where half of the face grew normally and the other half of the face did not. And this is more Perry-Romberg syndrome, not so much the en-coup-de-ça, but the atrophy of the skin that you can see occurring over half of the face. And you can see that very well occurring here where the cheek is very sunken in. There's a loss of volume and a loss of tissue occurring in this area, and even asymmetry occurring over the chin. And here is the limb, the linear morphea occurring over the limb. And as I mentioned before, when the morphea affects deeper structures like the muscle and the joints, you can end up with quite a bit of atrophy and damage and depression and sunken tissue. And you can see here really very significant difference between the circumference of both extremity, both legs, and also a limb length discrepancy as well, caused by the atrophy of the tissues. Sometimes you can get linear morphea that's not quite so dramatic, doesn't quite occur as deeply, but still occurring here, as you can see, in a linear distribution with the same clinical features that we were talking about before. And sometimes you can also get, because of the tightening of the skin, when you move your joints, it stretches skin that's already tight. And what that can sometimes do is cause breakdown of the skin, and you can get ulcerations and actual wounds that are occurring over those areas, which can get infected and can also be quite painful, as you can see in the photos over here. Another thing that you can sometimes see, particularly with the Perry-Romberg syndrome or the progressive hemifacial atrophy, is atrophy not only of the structures where the disease touches, but also atrophy of diseases that are not, of structures that are, sorry, not necessarily in the area that's of the involved skin. And so, for example, this patient had atrophy of the cheek on the left side, but in addition to that, you can see that there's also atrophy and asymmetry of the tongue on the left side as well. And so it's very important for patients that have facial morphea that we look at other areas other than just the skin. So inside the mouth, we also want to look at the eyes to make sure that we check and make sure that all the areas of the skin and internal areas are looked at as well, because sometimes you can miss disease if you're not looking. Another thing that has been described is involvement of the underlying brain tissue in addition to the facial structures. And so there have been imaging findings, so for MRI of the brain, associated with brain findings in patients with Perry-Romberg syndrome. And so for our patients that have facial morphea, we pay close attention to whether or not the brain is involved, whether or not patients have symptoms associated with that kind of involvement. And the most common symptoms that patients would complain about would tend to be seizures or headaches. When disease is also occurring over the face, particularly around the eye area, sometimes the eye can be involved as well. And so we tend to send patients with facial involvement to the ophthalmologist so they can have their eyes evaluated as well.
So once we identify that the patient has morphea, one of our things that we go through is explain to the patient what parts of this disease we expect to be able to treat with our medications. And the first thing is trying to prevent new lesions from happening, either new pigmentation changes or the shiny, thick skin. We try to prevent expansion of the existing lesions. That red border that surrounds the active lesions, we think is showing the direction of where the disease is going. And we hope to stop the red changes and prevent any more thickened skin in that area. We hope to limit the inflammation that we feel when Dr. Lamb was referring to the plaques. That is when you feel the skin feels deep, it feels thick, and it feels hard. And that's what we call an inflammatory lesion. And that tends to get better with therapy, whereas the sunken skin or the atrophic pictures that she had pictured, those don't respond well to medications and really require cosmetic procedures to fix that. That is a burnt out lesion, and medications might prevent new ones from happening, but really don't seem to help once that has already occurred. One of the interesting things about treating morphea is this disease often just stops on its own, and we can't predict it. Um, Most of the time, it doesn't come back. There are some people where the disease will keep coming back, but it becomes a really hard decision about how long to continue therapy for. That's really a discussion between the treating physician and the patient to try to figure out how much risk the patient wants to undergo in terms of stopping therapy and just watching. There's a lot of watching in this condition. We see patients maybe once a year or so just to check to see if the lesions that they had have now expanded while they're off therapy, especially the plaque type morphea. Um, those are often on the trunk. They might not be in a space that's particularly bothersome to the patient, unlike, say, the face or over a joint. But rather, if it's just a plaque on the back, sometimes we don't need to treat that at all, and we can just watch it and see if anything expands.
So how we approach treatment to morphea, as Dr. York mentioned, depends a lot on the patient's preference, also depends on the extent of disease. And so what we look at, in addition to active lesions, because that's what we're treating as active lesions and not burnt out ones, is where are the lesions located? Are they located over cosmetically sensitive areas like the face? Are they located over functionally important areas like a limb and a joint? Are they located in many areas like generalized disease, or are they single lesions over the trunk, where sometimes we think, well, the disease may burn itself out and we may not even have to treat? And so these are all things we want to think about when we're approaching treatment to disease. Now, when the disease is limited and when the disease is superficial, and so when you feel the lesions, I mean, you look at the lesions, you can see that they don't extend very far, and there's a surrounding erythema around the plaques, for example, that tells you that the disease is still active, or it's growing and the disease is still active. What we sometimes do is just treat with topical therapies, and this is something we use a lot in dermatology to treat other diseases as well. So morphea is one of them, one of our inflammatory diseases of the skin. And so there are various different types of topical therapies that we use, like tacrolimus, which is a non-steroid type topical therapy that is anti-inflammatory that we use, topical steroids, which we use a lot for various diseases in dermatology as well as in morphea. And there are as well vitamin D analogs that have been shown to be effective to treat plaques of morphea. Now, if the patient has more extensive skin lesions, lesions that are generalized, something we can consider giving them instead of topical therapies, because that's not very practical in terms of application, is phototherapy. And that is essentially medical grade light therapy that we give to patients that can cover a larger area of the body. This would be particularly for patients that have superficial lesions, because the light rays actually don't penetrate that deeply, certainly do not go as deep as muscle, and would not be something we would use if patients had deeper involvement. But for more superficial lesions that are generalized, phototherapy can be a very good option. And then if the lesions are occurring over sensitive areas like the face or the head or a limb, or we're thinking the disease is rapidly progressive, or the lesions themselves are very deep, then oftentimes what we'll use is more systemic therapy to try to really halt the disease process, because of the extent of the sequelae that we have seen in the previous photos and how functionally disabling this disease can become if left untreated sometimes.
So about 10 years ago, a group of juvenile dermatologists and rheumatologists got together to discuss how to actually approach this disease in a systemic manner, because until this group met, the treatment for morphea was really helter-skelter. Each group was treating it slightly differently. So even though the same medications were being used, they weren't being used in the same manner and at the same doses. So this group got together to try to coordinate how we actually treat this disease. And we've moved, in adults, we've taken what they've come up with for children and used pretty much the same approach. So this shows on the top that was how corticosteroids, which are drugs like prednisone, and another drug that we use a lot in rheumatology called methotrexate. On the top, that the different colors of that pie chart show how each of the members in that group were dosing those medications. And you can see that there was a large, diverse approach to dosing these medications. And what they decided was to either give methotrexate as an injection this was in children, as something 1 milligram per kilogram subcutaneously for a year. And for the steroids like prednisone, to either not use it, which is in the yellow, the no corticosteroids, or to give it as prednisone orally, or to give it intravenously. So there were 3 different approaches to corticosteroids and really one approach to using methotrexate. So we use the same treatment regimen, although methotrexate for adults is often given as a pill, so that makes it a little bit easier. We treat any type of facial involvement of the skin when it's overlying joints, because it can lead to permanent decreased range of motion of the joint if there's a large amount of skin involved, and if somebody has rapidly progressive disease. Now, we offer patients who don't seem to have very aggressive disease, if it's asymptomatic, if it's not in a cosmetically difficult place, we can just watch. And often the lesions will just go away on their own or stay stable. We follow patients for years just to monitor them, because sometimes this disease just stops on its own. And we look for signs that the red border has faded. We look for a lack of development of new lesions to sort of assess at what pace this disease is going. In children, it's a much more rapid progression. In adults, sometimes people are not quite sure when that lesion appeared. They just they noticed it one day. A family member might say, "Oh, I've seen that on you for years." Adults often don't know, especially if it's just a plaque on the back. Sometimes it's hard to tell exactly how old that lesion is and how active it is. So methotrexate is a drug that rheumatologists use all the time for rheumatoid arthritis. It's very, very common. It's been around for a long time. You can take it as pills or use it as a subcutaneous injection. It's dosed weekly because if you take it every day, there's more side effects like ulcers developing in the mouth. And so we usually use in adults 6 to 10 tablets of this medication once a week, and give a vitamin called folic acid to prevent side effects. And the big side effects are developing painful oral ulcers in the mouth. And over time, this drug can cause liver damage. So we check very closely about every 3 months blood tests to monitor the liver. When patients are of childbearing age, it's just very important to know that you can't get pregnant on this medication. It can cause birth defects and spontaneous abortion, miscarriage. So we are very careful when we give this medication to women who are considering pregnancy. Steroids, prednisone, for example, can be either by mouth or intravenous infusion. This works, it's probably our fastest acting medication we can give, but it has a ton of side effects that can really limit how you use it, especially if people are on it for a long time. It can cause substantial weight gain, especially around the face. It can increase the risk of diabetes. It raises the blood sugar. It makes people more prone to infections and can often cause mood changes and irritability. So if something is not particularly bothersome, if somebody feels that the lesions are something that they can live with as they are, we often don't give steroids. But if it seems to be progressing very quickly, we might start with a rapid course of steroids and then try to taper them off of it. Now, for patients who don't do well on methotrexate or steroids, or they get side effects, we use a drug called mycophenolate as sort of our third line agent. Goes by the trade name Cellcept. We use this a lot in lupus, and it's commonly used in patients who've undergone a kidney transplant. These are pills. It's not safe in pregnancy, so we're careful about who we give this to. But it's a very well tolerated medication we can use for several years without a lot of toxicity. So I think just to go through some conclusions, the first thing we want you to remember is that Morphea is not systemic sclerosis. This is a different disease process. And even though it's limited to the skin, and the lesions direct and the areas directly under it, like the tongue and sometimes the brain or the eye, this does not cause a lot of internal organ involvement. So it's not the same disease as what most people talk about with scleroderma. And one of the keys when somebody comes in to see us is that they don't have that Raynaud's phenomenon that's very common in scleroderma. So the fingers are not turning blue in response to the cold. There are not the blood vessel changes that we can see in the fingers. And unlike the systemic sclerosis form, where it usually starts in the fingers, and the fingers are almost always affected in systemic sclerosis, in Morphea, it often spares the fingers. So that's one of the key things when a patient comes in and they're very worried about which type they have, is to look carefully at the fingers. We can see vascular changes in patients with systemic sclerosis that we don't see in Morphea. We can see thick, tight skin in the fingers, which we don't see that much in Morphea. And some of the other aspects of systemic sclerosis, like lung and heart involvement, we just don't see in Morphea. And we wanted to show you a lot of these pictures today to sort of go through and have you understand the parts of the disease that we can treat, which is the thickened skin, new lesions, red inflamed areas of skin, and some things that we can't. When we show the pictures of sunken skin or the pigmentation changes, those don't respond very well to medications. So hopefully you learned a lot today, and we appreciate this chance to talk to you about this disease. You can email me with any questions at that email address, and we'll be available now for questions in the question and answer session that follows.
Thank you so much.